Matt and Carl, welcome. Thank you very much for joining me today. I know that you're here on a whistle-stop tour of the UAE, and we've squeezed this podcast in. And what we would like to talk to you about today is your pathway in the veterinary medicine field, but also the zero pain philosophy. So you founded this in 2016, and it is an online CPD platform and telemedicine service for both vets and veterinary nurses. I'd like you to tell me a bit more about that, but also how you ended up here. So from the beginning of your career, your decision choices, and now you're in the seat with me today.
Cool. I'm going to let Carl start with the career path. You go for it.
Well, thanks. Yeah, no, thanks very much. And thanks for having us in the UAE as well.
Our pleasure.
So my pathway, where did it start? So I think when I think back to being at school and deciding at some point I was going to be a pilot or I was going to be a vet. Pilot obviously didn't work out because
I say the same thing.
Yeah, you're going to say the same thing.
I mean, they're very different choices.
Yeah, and I don't know why, but I think maybe everyone at that age, they wanted to be a pilot. So no, I decided I would be a vet. First year around with my A-levels, actually I didn't get my grades the first time, so I resat my A-levels and I did get some grades, and then I had a year out and went to vet school at that point, which was at Liverpool University. So probably around that sort of time, it was very much a really big equine hospital. There was very little small animals, so it was really focused on equine. And actually that's really what got me excited about then anaesthesia. So that gave me the idea that probably I'd want to do something. We had a great anaesthesia team, and that was linked to the human hospital in Liverpool, to the Royal Liverpool.
Well, that's really, is that usual? Is it still the case now?
No, I think that link has kind of like gone, but actually at the time we were there, the professor of veterinary anaesthesia was the professor of anaesthesia across both the medical and the veterinary schools. But I think that role has probably changed. There was a really good collaboration between the two sites.
That's interesting, because I went to London, and London is very much just veterinary, so there was no collaboration, which I always think is a little bit of a shame.
It was exciting.
Yeah.
So when I graduated, so 2002, so just over 20 years ago, I went into mixed practice, which was in the Staffordshire Moorlands, so a very rural area of the middle of the UK. And I spent about just over 5 years doing mixed practice, lots of farm work, and some equine, and more small animal work as well. And that was before then I did my residency. So I went to the RVC, to the Royal Vet College, to do my residency, and also to Davies, a specialist, to a private hospital. Did my residency, and then I stayed at Davies for a short time. And then I moved from there to the university, back to Liverpool actually, and I worked as a lecturer at the university for a couple of years. And then after that, I kind of went out by myself to do more consultancy work and to provide locuming in specialist anaesthesia. So that was my kind of pathway to then reaching the point of where I am now, which is at Anderson Moors, which is a private hospital.
But you're still doing the education?
Yes. So that's kind of, I suppose, my kind of bit in the day. And that's really, I think it's really valuable and important that we do clinical work so we understand what's going on, how the profession's changing, what's new, what's different, and also from a teaching point of view. So we have a very big team of interns and residents, so the more junior vets in the hospital, and we're involved in their training. So we train anaesthesia residents to become specialists, but we also kind of nurture and mentor the more junior intern vets as well, as they're looking to perhaps specialise as well.
That's amazing. Do you do any research within the referral centre as well?
So we're very much involved in doing clinical research, and I think that's really important to emphasise that we're looking to look at areas of practice that are going to make a difference on the ground. So we're not talking about research that's going on perhaps in the more academic environments where it might be more basic science. We're talking about application. We're really wanting to focus on what's going to make a difference to you in the clinic. And what can we apply that's going to be a great thing that's going to either improve patient safety, improve kind of like the experience of the pet through the hospital. That's really what we're focused on, and that's what we're able to do, particularly in the UK where there's quite strict legislation around what you can do with an owned pet versus what someone might do in a more experimental setting. So we're really focused on that aspect. So that's a great part of the role, and the teaching part and the mentoring is really quite exciting. And then outside of that, the education part, so training vets, nurses in primary care practice to upskill themselves, improve their own kind of medicine, improve their own practice. That's the other part of being a specialist. It's a really important part of, I suppose, kind of nurturing and actually imparting that knowledge in a great way so that people can actually use it.
Yeah, true. It's very all well and good determining how to improve our methods, but if you're the only one that knows, that's not that helpful.
Absolutely. Yeah, one of the reasons we set Zero Pain up is to share that knowledge. So yeah, we can definitely talk more about that.
Perfect. And how about you, Matt?
I got really interested in veterinary medicine in my kind of teenage years. I worked on my aunt and uncle's farm in Devon. They were dairy farmers in Devon. They are farmers still. And I spent a lot of time working on the farm when I was younger. And then I got to spend time with the local vet practice, Dartvale Vets in Devon. And I just really enjoyed working with the vets, going around on the calls. So completely mixed practice. This was it would have been over 25 years ago. So very mixed. So you'd start the day consulting, doing small animal consults, then you go out and do some farm work, you'd see some horses, back in the practice in the afternoon. And yeah, that's what really piqued my interest. And I eventually got a place at Liverpool University. I think both of us didn't have the most straightforward route into vet school. It was really challenging.
I actually don't think anyone did. I would say I didn't either. It's not as easy as that, is it?
Yeah, got there, enjoyed it, had a brilliant time at Liverpool, wonderful city, amazing university, and then graduated, went into mixed practice because I was interested in doing everything. I did really enjoy the farm and the equine work. I think, like Carl said, coming from Liverpool, such a great, strong equine hospital, really interested, very well taught. And in mixed practice, I enjoyed mixed practice. I found it really challenging. I think there's a huge art to mixed practice. You have to be really good at a very wide range of topics. And I think I struggled with the fact that I couldn't take my knowledge deeper on a lot of these topics because you can't physically do everything. And I thought, well, what's the one thing that I can do where I can deepen my knowledge in a particular area but still maintain that mix, work across the species? So I thought cardiology, ophthalmology, anaesthesia, and I was very fortunate. I applied for an anaesthesia residency at Liverpool and I got the residency, and like they say, the rest is history. And I went to Liverpool, I did a 50-50 residency, so half small animal, half equine, some farm cases in between there. And by the end of the residency, I came out of it with a really strong interest in pain management. And that a lot of it is thanks to some of the people I met and worked with along the way. Good friend and colleague, Dr. Izzy If, who works at the University of Bern in Switzerland. Izzy really inspired me in pain management. And yeah, here we are, however many years later. So.
And did you both meet at the University of Liverpool during your residencies, or how did you decide to work together on this? Or is it sort of in private practice?
Yeah, good question. So we did go to university, but actually I was a year above. We didn't really know each other at uni. So really interestingly, it wasn't until...
I didn't know you'd specialise in the same sort of area.
So it was kind of through then, I suppose, actually a mutual friend of ours, another anaesthetist, who kind of introduced us a few years out from uni. And that kind of sparked that kind of relationship between the two of us. And then kind of moving on from there, we both worked in different kind of hospitals, but we were both involved in management, in anaesthetics.
And education.
And education as well. And then interestingly, I suppose, then it kind of fast forward a few years, and actually zero pain philosophy came about in New Zealand.
Really?
Got a friend who actually did his residency in surgery with Matt at Liverpool. And we were in New Zealand, and this concept had kind of started to be talked about, and that's where it got born. So the philosophy itself was something that was generated out of a sitting around planning a CPD course. And Brent Higgins, who's our friend in New Zealand, he'd been thinking about how this could be going to be rolled out in a great way for the vets that he was working with, and that's where it where it came from.
I think sometimes the stars kind of align, and I'd always thought, okay, how can I give back? What's my contribution as a specialist? And I thought, okay, I've been in that situation in practice where you're going, okay, I've got a case in front of me, how do I deal with this? And there's always that one person in the practice, right? I know I'm going to ask this person about this and this person about this. Well, this is what I do, and this is why I do it, but I don't really know. I think, like I say, you have that really broad range of knowledge that you really need, and there's only so deep you can go. And all of my research and all of my educational efforts are really thinking about helping people back in practice. So if I was in that situation again, where can I go to find information? Because when did I go into practice? 2003. I'm trying to think. I graduated in 2003. You'd open a textbook, and the textbook could be 5-10 years out of date by the time you opened it. And then what we want to be able to do is for people to go, right, I've got this problem. Now, it's not about loading information into your brain, which is how I felt I had to be at vet school. I had to know everything. It's about where to find that information. Right, I have a dog with pancreatitis. What's the best thing to do? Okay, go on the website, type in pancreatitis, it's got all the latest information.
Because it's not possible to hold the latest information in your head.
No, you can't.
It's just not.
And the other thing we found is that we were doing a lot of CPD. We'd go and do an evening here or a day here, and you'd write notes. And you know, it's like you turn up, you do your day of CPD, you sit with your notes, you get really focused. You think, this is great. Then what do you do with the notes after the event? Do you ever look at? I bet you
no.
Only 20% of people ever look at their CPD notes. And I thought, this is really silly. But if we put it on a website, we can keep it up to date and people know where to go to for all that information. So yeah, hopefully we've moved with the technological advances that life is giving us. And the aim is to help the vet or the nurse or the physiotherapist who has that patient in front of them saying, right, what's the best thing to do in this situation?
I've only just let go of the notes that I made at university, and I keep all my CPD notes, but because it makes me feel good that they're there. Makes me feel safe that they're there, but could I find what I was looking for if I was like, well, what's the dose of this, or how should I give this?
Yeah, and maybe you went to a great CPD 3 years ago, but something's changed, and actually, boom, 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 we just go on and we update. The pain update section of the website is the kind of classic example where something changes, there's a new product or new thoughts on a product. We okay, right, we're going to write a pain update on that because we feel there's information to be shared, and also further references to direct people to.
Wonderful. So tell me more about the zero pain philosophy. What do you offer? How can vets access it? Because of course the other thing about being online is that it's worldwide, which for us here in the UAE is wonderful because we are a much smaller community. We don't necessarily have the referral infrastructure that we would have in Europe. So we're always looking for readily accessible, up-to-date information. So can you tell me more about that?
Like Carl says, the concept came about in a conversation with our friend Dr. Brent Higgins in New Zealand. And there's the Kiwis I love the approach to life that New Zealanders have. And there's this kind of phrase, world famous in New Zealand, and almost the approach that actually, if you're a Kiwi, you can do anything. And we were really inspired by Brent. I thought, well, why don't we do this? Let's just start this. And part of the original concept was to try and bring analgesic excellence to everyone in their clinic. We thought, okay, it's when nerve blocks are really taking off and there's a load of interest around nerve blocks. Let's just get our phones out. Let's just make videos of the techniques we do every day. So if you're a vet in practice and you think, well, I've read about this incisional block, for example, but how do I do that? I can go on the website, I can watch the video, I understand that technique. I can watch the video as I've got my patient in front of me and I can perform that technique. Then I can review the video again. I can think, okay, what would I do better next time? That's the whole intention of how we started, was just to bring those things to life and put them in the hands of the people that need to use those techniques every day. Have you got anything else to add on the intention and inspiration?
Yeah, absolutely. And like, the key was, to start with, it was you'll get the phone out and do it right now while we're doing something. So that was a really great way to know, actually, these are things we were using in practice. And I think the other thing I really noticed before we started to do that kind of content, or it became more widely accepted, there was a difference between what someone in primary care or in GP practice thought about what happened in referral practice. They thought we were doing something that was wholly different. and
One
it
that you
wasn't
had magic
achievable.
drugs that we didn't
Yeah,
have.
absolutely.
Yes, I had that idea. I was like, no, it's okay.
This idea, and I think the whole profession is to kind of demystify this almost like ivory tower concept of you're in this beautiful hospital and everything's wonderful, but it was trying to, to kind of demonstrate that you can do an amazing job. You don't need to have loads of bits of fancy equipment, but you can still do great analgesia and great pain management without that. And that's really kind of the focus. And, I think as Matt mentioned, that kind of started there. And I suppose the next catalyst was COVID, because COVID hit, and we went from this concept that was just something we did, we weren't in our day jobs as such, to an opportunity then to think a bit more differently about it. And that's when we started to kind of upscale what we were doing and what we were offering, as we couldn't do face-to-face teaching very easily. So then the webinar side of things kind of came out of COVID, really. So,
and you're still doing full-time day jobs and then doing this on the side.
Yeah, absolutely. I think that's a really important thing about being able to impart knowledge, is knowing what you would do in that situation. So for advising people, then it's great to have known, actually, when I had that same or similar situation, this is what I would do. And if you haven't lived it, it's really hard to talk to someone around how they could do it differently, how they could improve.
So you don't see yourself retiring from clinical work anytime soon?
Good question. Yeah, I think we go through phases of going, what you've been doing something for such a long time. You think, I want to do something slightly different. But I think having that bit of clinical input is a great part of being a vet as well. Actually, we can do lots of different things, but ultimately come back to to treating pets. And for us, that pain part is really important.
I think it as a vet, listening to you and utilising the website, it makes it very authentic to know that you are still practicing and you are doing all these things every day. I think it does lend some authenticity to that from a vet in general practice. Definitely.
I think sometimes the way I think about it is actually it's an honour and a privilege to be able to help people's pets. I think actually we are trusted to provide the very best that we can possibly do it in that situation for that individual pet. And yeah, we are very fortunate that I think we forget that. You graduate with a vet degree, and so that I think honour and privilege is quite a good way to think about it. Yeah.
So how can practices and clinicians here in the UAE, can they get involved? What are they able to access? And how do you see the zero pain philosophy growing? Like, what world domination?
World domination, yeah. Well, we started with the ambition of we are a global platform, so all of our content is written with a global audience in mind, and we've done that almost in parallel with the way WSAVA, the World Small Animal Veterinary Association, are thinking and moving. WSAVA have a complete global outlook, and we thought, okay, from a pain perspective, we are very much aligned with the approach they take in writing guidelines that are applicable to people in a variety of regions of the world. I guess the first way that people can engage with this is on our socials. So Instagram, Facebook, LinkedIn are where we post all of our information. We normally post at least 3 pieces of information a week, so that all of those are not just pretty pictures that we post. There is a message in every single piece of information we post, and if you want to engage further with that, you will find the information on the website, zeropainphilosophy.com. We have part of our website, there's a whole host of the website which is free to access. So the pain update section, those are informative pain topics. So areas where we think, okay, this is something new, we'd like to update our community on this. We have our nerve block videos. So like I say, you can go on there, you can watch any nerve block technique if you think, well, actually, I haven't done an epidural for a while, or I've heard that a sacrococcygeal epidural is a great thing to do for a blocked cat, for example. Let's learn a little bit more about that. I want some resources on pain scoring. All of the information is there, free to access. We also have a subscriber side of the website where you can subscribe and gain access to our webinars on a monthly basis. We publish 10 new webinars, at least 10 webinars a year. We've also got our podcast as well. The podcast is free to access and it's available on all of the major platforms. So yeah, lots of ways you can engage with us.
What's your particular area of interest? That question is directed at both of you.
Good question. I think for me, my area is really around acute pain management. So what we're doing when the patient is either having maybe some sort of surgical procedure or has had some sort of injury where we've got that very acute phase of either surgical or perhaps traumatic origin pain. So that's kind of my area. That is what I spend most of my days doing when I'm in the clinic, and also most of the time in terms of teaching. So that's a focus for me. That's just the kind of the other aspect of pain.
Yeah, so I've always been really inspired with chronic pain. I think the thing that I love about pain, and it's really interesting when you said, do you think you'll ever retire from clinical practice? My brain will never stop thinking about pain. And I love the fact that we do not understand everything about pain. Okay, some people, that would really frustrate some people and say, okay, if we don't understand everything, how do we manage it? I love the fact that there is a continuous education piece for me there. And I go and sit in human conferences. I went to IAS, which is the International Association for the Study of Pain, brilliant human pain conference. And you sit there and you just get mind blown. But I feel my job there is to, work out, digest the information presented and work out how to present that back to, like I say, our global pain community. So chronic pain is my main area of interest. I run a pain clinic. I've run a pain clinic for over 10 years now. So I see chronic pain cases, arthritis, neuropathic pain, post-surgical pain, lots of cases where a dog or a cat has a behavioural issue and pain could be a contributor to that. So lots of cases that have seen a behaviourist thinks, hang on, is pain part of this problem? Let's refer the patient to a pain clinic. So that's a lot of my work. I really enjoy the acute analgesia as well. I love nerve blocks and I really like performing ultrasound guided nerve blocks. So working with those surgical cases in the acute phases. Some of those are relevant for some of our chronic pain patients as well. So there are some patients where we will bring them into the hospital, anaesthetize them or sedate them and perform some type of interventional nerve block if there's a type of pain that we're trying to specifically target. So yeah, those two things are kind of nicely interlinked.
The questions for you actually, based on what you've just said. As veterinarians, are we a long way behind human medics when it comes to dealing with chronic pain? Because I'm not sure human medics are, depending on the condition, looking from a woman's health perspective as well, not always. I think there's still a lot to learn that we don't understand there.
Yeah, that's a really... I'm going to say it's multifactorial. It absolutely is multifactorial. If you sit in a human... Certainly, if I come from a UK perspective, sitting in a pain meeting at the Royal Society of Medicine, what you'll hear is, from the human pain specialist, is, I wish I could do a better job, but I just don't have time. I'm expected to see 60 patients a day, and that's insane. Okay, I might see 3 patients a day, and I have an hour with each patient, so I can really get to the bottom of what I think where I think their pain is coming from. Spend a lot of time talking to the caregivers. We then think about medication strategies, all sorts of lifestyle strategies. So we're very fortunate in that regard. Pain is one of those areas where the knowledge level and the understanding is much higher than our actual ability to address the problem in lots of situations. And I guess one example there is, we have drugs that we can use to treat pain, but those drugs often come with high level of adverse effects. I guess if you think about people and gabapentin can be a really effective drug for managing neuropathic pain in people, but it comes with adverse effects. And so that person has gone to the pain practitioner, they know what they need to have prescribed. It is effective managing their pain, but it affects their lifestyle. So they can't drive, they can't work, they can't sleep. And then they have to go back to the pain specialist. So yeah, there's that understanding piece with understanding the pain. And there's actually, do we actually have the practical options available? And do we exist in a system that allows us to do that? So in the UK, the NHS, probably not. In other healthcare situations around the world, maybe there is more of an opportunity there. that it is a difficult situation. I think the desire is certainly there in the human world, in the veterinary world, to do a much better job. It's the system enabling us to do that job in a way.
I hadn't thought that we have a certain level of advantage over a human medic because our pets don't need to drive or, work.
Yeah.
And the compliance depends on their owner rather than, which does have its challenges, I suppose, sometimes. But
I think we're really lucky, certainly in the acute set. I always say this when I'm talking about pain scoring and post-operative analgesia. People will always say, I had a nerve block and it was amazing. But when it wore off, it really hurt. And I was pushing that buzzer and it took them 2, 3, 4 hours to come and give me some morphine or whatever. And then I felt better. We do an amazing job in the vet world. We're hot on pain scoring. We're pain scoring our patients. Right, okay, that patient's painful. It's an hour out of surgery. I'm going to give it some methadone, for example. I'm going to give it now. It's going to be working within 5 minutes. I think our dogs and cats are often treated much better than our humans as far as their analgesia needs go.
Would you agree, Carl? And what pain scoring, how do you assess pain in your post-operative patients?
So just to pick up what Matt was saying there around how we kind of manage that kind of acute pain phase, and something that I think we both absolutely agree on and we see is good acute pain management is often the key then to not getting chronic pain. So dealing with it really well in the hospital setting so that we can then avoid, or we hopefully kind of minimize, reduce the chances of getting chronic pain. So great acute pain management is key to that. I think they recognize that in people as well. And that's the bit where the human medicine often falls down purely from a capacity point of view. Whereas I think our vet nurses are great. They're there, they're watching the patients, they let you know, and they're intervening. They're getting, obviously, the vet involved much earlier on than they can do in human medicine.
With humans, are they worried about the use of certain pain medications becoming addictive? Do you think that's why they hold back?
And so I think there's two aspects to it. It is definitely addiction. So we're talking about opioids that are usually prescribed for acute pain in the hospital setting in people, then that's a big problem. And then there's perhaps tolerance to those as well, and also getting other pain effects associated with hyperalgesia, particularly with opioids, quite well documented in human medicine. So both tolerance and addiction. So you need a higher dose to get the same effect. And then the consequences of prescribing opioids for long term is then addiction. So there's definitely concern around, and I think, we're aware in certain countries, in certain health settings, then opioid abuse is a considerable problem to prescription drugs as well. So I guess we don't have to deal with that in our patients, in our pets, but I don't think we don't recognise, and actually back to your question around kind of assessing pain, is actually we struggle to assess the pets that we are treating because we don't really know all of the key signs, all the cues that they're showing us as well. So training the teams to be able to recognize pain is a really important part of pain management. And a bit of focus on it when we're talking through things is around some of the guidelines that are out there. So from the American Animal Hospital Association, they have some pain management guidelines, and also organizations like ISFM, to the Feline Medicine Society, where really the first part of pain management is, it's not as simple, I feel, as just giving a drug. We've highlighted that that's somewhere where perhaps overprescribing is an issue in human medicine. It's easy to prescribe something than it is to perhaps understand more. So recognizing pain is really the key then to being able to treat it effectively. So for me, and I think in the hospitals where we're working, then we're really focused on either, I suppose we're mostly now dealing with dogs and cats in the hospitals where we work, and we recognise the species differences. So number one, what a cat does when it's in pain will be different to what a dog might do. So that's really important. We can't, generalise across species. So we're using pain assessment tools that are targeted for the species. And the other is we want to use validated assessment tools as well. So in human medicine, they'll ask us, how do you feel? And where would you rate that on, 0 to 10, for example, or 0 to 100? Obviously, we can't ask Fluffy the cat whether that's how they feel. So we need to use other methods to assess. And that's where the challenge lies, because then there's maybe bias of the person doing the assessment. And also there'll be just the peculiarities about being in the hospital environment. So dogs and cats, they don't like being away from their owner.
Cats particularly, I have always found that to be a challenge. So yes, what would be your recommendation to assessing pain in cats in particular, especially if they're hiding under the blanket, or they're, because they're frightened, or because they're painful, or...
I mean, we've seen a great development, I think, over the last sort of decade or so. There are multiple tools available. So depending on the setting, where you are, how you operate as a hospital, then there are various ones that are available. But in cats, the two key ones that I would be using, so there's a system out of Glasgow, the feline acute pain scale, and then the feline grimace scale. So that's the most recent of the developments, and really out of human medicine, particularly non-verbal humans, so talking about babies, some children, where they're using pain assessment based on facial symmetry or asymmetry, depending on what the situation is. And that's really what's developing in some of these other species, so particularly in cats, where the face is relatively similar. In most cat breeds, they have a relatively similar shape. Then there's great work there in using that to then assess pain. So the feline grimace scale is a great example of this. And now they're incorporating AI technology into that. So...
Oh, really? Because it's completely hands-off, isn't it? It's, the minute we try and take a heart rate or a respirate in a cat, they will get...
Exactly, and that's the other thing. We're interacting with them. So it's really important to assess pain taking a step back.
At a distance.
The moment you try to do something,
they're
going to change.
Almost.
Yeah, absolutely. And the Glasgow system also incorporates kind of pain faces or, facial expression. So you can pick up on certain things like the shape of the muzzle, shape of the eyes, ear position.
I won't make you do an impression.
Flattened ears.
So that's great. So for cats, that's really good progress in cats.
And there's the Boticati pain scale. So I remember writing an article on feline analgesia when I first started my residency, 2006, and there were no validated pain scales for acute pain management. The only validated pain scale we had was the Glasgow pain scale in dogs.
Yes, I don't remember learning about it. I was at university then.
And at the time,
particularly,
people say, well, you can't score pain in cats. I don't personally think it's difficult to pain score a cat, and we have those three tools. And I think with what I'd encourage people to do is get some experience around each of those three tools.
You get better as you practice.
Yeah, feline grimace scale, the Glasgow pain scale, and the Boticati pain scale, because it gives you then develop a real understanding of how feline behaviour changes with pain. And I don't think it's difficult to spot a cat that is in pain. And I think what we always say is, if you think they're in pain, give an analgesic and go and reassess them. And there is a piece of learning there for us to say, well, actually, that cat did have its ears flat and its whiskers were really held tense. And then I gave it some analgesia, and it's a completely different cat. So there's always a piece of learning there.
Do you teach owners to pain score their pets?
It's a tough one in the acute setting for owners to do that. The other key there, so we mentioned about pain assessment is really important. Giving analgesia is really important, but it's also reassessing, and that's the key. And often where clinics or where practitioners are great, they recognise pain, they treat pain, and then it kind of stops at that point. So it's going back and going, actually, did my intervention, was it effective? Was it the right drug? Did I give the right dose? And making sure that we get that bit right, because we have great understanding now that we should be giving analgesia for as long as that kind of painful stimulus is around. And the risk is if we give analgesia for too short a period of time, that's when we might generate, for example, some sort of chronic pain type setting. So it's picking that up and knowing that we've done a great job.
A really good resource that's just been launched by a Brazilian anaesthetist called Professor Stelio Luna is the Vet Pain app. So he led the development of this app, which has all of the validated pain scales in it. And he wrote a pain update for us on zero pain philosophy. So if anyone wants more information, it's there on the pain update section, or you can download the Vet Pain app. the other person we had a really good conversation with earlier in the year was Professor Paolo Stigall, who developed the feline grimace scale. And when we talk to him, there are a lot of caregivers that are also using that app. So it is really easy for a caregiver to use. Yeah.
They're collecting amazing data because they're asking, you can obviously photograph your cat using the app, and then it obviously picks it up. But they're also then collecting those images to create this amazing database. And obviously the tool becomes more powerful. The pain faces and the pain kind of AI technology is great in cats, but then one of the challenges that when we talked to Paolo about this as well is there's so many different dog breeds and they have very different conformation. So you can't use the same technology and then assess a number of different breeds. So really in dogs, I'm focusing in the hospital on using the Glasgow, the short form of the Glasgow Pain Scale for dogs. And we've got a lot of understanding and great use of that over many years. So as Matt mentioned, one of the earliest of the validated tools was the Glasgow system. And because of that, I think we use that very successfully in the hospital in the acute pain setting. And again, it's down to training and everyone understanding what they should be using it for, how we assess, and using it correctly. So there's two ways to use it in the ambulatory and the non-ambulatory dog, and it's just making sure that you use the correct, you're scoring out the correct number, and we're scoring it correctly, so we don't miss those dogs that are painful. And that would be my other kind of, either take home around using pain assessment is trying to avoid missing the dogs where we do think that they are painful. Either they're sleeping or they don't walk, and then we score them low. Actually, the fact that we didn't try and get them up and make them walk means we miss those ones that are painful. And that's a big bugbear for our orthopedic surgeons, actually. So if the nurses don't get, for example, dogs have surgery for cruciate rupture, very common orthopedic surgical intervention, they score them low. Overnight, obviously, they're sleeping, they're resting, which we're encouraging them to do that. We don't want them to be getting them up all the time. But come the morning, the physios get them to do their physiotherapy the next day after surgery. The moment the physio gets them out of the kennel, they can't weight bear. They're really painful. The surgeon's asking why they didn't get analgesia overnight. And it's like, well, we scored them differently. So it's really important to use these systems, how they're designed to be used, rather than can't really tailor them to the clinic as such, and we can't really tailor them to the situation. So using them in their full format, definitely.
And I think one of the things we talk about the concept of preventive analgesia, and part of that is pain scoring the patient and making sure that we provide analgesia for as long as they're painful for. And I think that's a really good example, because in a dog that's had stifle surgery, if we've done a nerve block, we've used bupivacaine, it's a long-acting drug, 8 to 10 hours, that's going to work. So that nerve block's going to wear off during the night. And I think that probably does coincide with the time when the pets should really be sleeping. So I think I'm probably just sharing a challenge, really, which is those patients, they are very well at analgesics, but some point during the evening, around about midnight, maybe the dog is sleeping, the nerve block is wearing off. If we aren't interacting with them, there is a window where we're missing them. So, okay, either we say, well, do we just leave them sleeping and give them opioid analgesics so we know that they're well managed, or do we wake them up from sleeping to pain score them to give them opioid analgesia? Or do we need to be thinking about adding something else in there analgesia-wise to optimize?
So you also think when the physiotherapist gets them up and starts doing, it's going to be sore, and do you analgesics before, during, after? Do you pain score before, during and after? Because you're asking them to do something totally different, aren't you?
One of the things you mentioned about research and what research we were doing. One of the studies that we're doing at the moment, I say we're coming to the end of it. It always takes forever to finish a study. We're looking at a study looking at the combination of paracetamol and non-steroidals in dogs undergoing orthopedic surgery. So this is that kind of classic example. The dogs have had an opioid in their pre-med. They've had an effective nerve block. We've got 3 groups of patients, either non-steroidal or paracetamol, or the combination of non-steroidal and paracetamol. And we're looking at pain scores, we're looking at mechanical threshold testing, and we're looking at opioid requirements in those patients for the 24 hours after surgery. So the combination of non-steroidals and paracetamol is something that hasn't actually been examined in dogs. I know a lot of people are doing it, and maybe some people listen to this podcast and thinking, oh, I haven't heard of that in dogs. That might be a new thing. We are looking at, so the question is, does the combination confer an advantage from an analgesia point of view? And maybe we might find that is quite a good solution to these patients that we're talking about.
Definitely. I mean, I recognise now that we need to do regular pain assessments. So if we go back to the cruciate surgery, because it's a really good model to look at. It's a very standard surgical procedure. It's a relatively homogeneous population of dogs, that we regularly pain assess them over the first sort of 8 to 10 hours to make sure that we understand what's going on, and then we can get things right before, as Matt mentioned, before then they're likely to be sleeping overnight. But we do understand, like the opposite to that is we don't necessarily want to give analgesia, so opioid analgesia on like, by the clock basis, because we've got some information then to understand that by doing that, we're likely to worsen the outcome in terms of how they recover. So they're more likely to be sedated for giving opioids. They're likely to have lower food intake. They're more likely perhaps to have regurgitation, for example. So those sorts of aspects. So we think by blanket dosing, we're covering their pain, which of course we will be. But by the fact that we give opioids and we're perhaps over prescribing, we then create some side effects associated with giving them. So pain assessment, we're doing it on a regular enough basis. How do we pick up when they become painful and then tailor it from that point? So I guess I've changed the way that we do that in the hospital just to make sure that we don't miss those ones, because if they are asleep, we don't want to wake them up. So it's trying to get the timing right. We obviously have to get the buy-in of the other team. So we want to make sure that the orthopedic surgeons are happy, because otherwise they don't like that kind of approach and they want the blanket dosing. So it's a real challenge to get the balance right and make sure that we want everyone to be on board. I think that's the thing with pain and its management. We've got to get the buy-in from the other teams to make sure that we are doing it correctly. We're obviously serving the patient as the primary thing, but we've got the other teams have got to be happy.
If you could give sort of your top 3 tips to a general practice as to if they wanted to optimize their pain management, where would they start? Would they look at their perioperative pain management? Would they look at chronic pain management? And where would you direct their focus initially?
That's a really good question. No, it's a really good question. I mean, I would go with the peri-op.
Okay.
I think that is the key. I think number one for me is the ability to recognize pain. I think that's got to be the key, and that's around training. So making sure that everyone understands, what we're looking for, what we're going to use to recognize that, and then how they would apply that pain assessment tool. So what do they need to do to get the score at the end of it? So that's the key, recognizing it, definitely. Treating, so making sure we've got some way that we're going to treat pain. And I think that's a really nice thing about what we're demonstrating with Zero Pain is there are multiple ways to do that. And in every setting, there'll be something that's slightly different, access to particular drugs, what you can get hold of, how you use them, whether you're 24/7, whether you're sending the pet home to be with the client, with the pet owner. So all of those things will have to be on a more individual setting. Once we've done the treatment, it's the reassessment. So we really want to make sure that we've got the ability to reassess and decide if our intervention, so whatever we gave, has that actually achieved what we were wanting to do. So those are my 3: assess, treat, reassess.
Brilliant. Thank you. Matt, before you give me your top 3, because I have another question and I was like, I need to squeeze that in. You mentioned briefly about you get a lot of referrals from behaviourists.
Yeah.
Unsure whether the behavioural problem has a pain. This is a challenge I think every vet faces on a daily basis in general practice. Ballpark figure or how you feel, how many of those referrals are down in some form of those behavioural referrals are down to chronic pain? Do you think it's commonly misdiagnosed or missed in general practice?
I'm sure it's definitely missed. I would say probably 50% of those cases where there's a behaviour problem, and if the behaviourist is suspicious of pain, I think I'd probably find that 50% of those cases would benefit from a pain assessment. So I guess what I would say is put it high on the list. If you have a behavioural issue and you think, is it pain? Could it be pain? Then I would go down explore that avenue. Definitely don't miss that, because it's just really hard to get any traction on the behavioural management of those cases if pain is the driver. I was going to actually go back and go in on the kind of acute perioperative element there and think about multimodal analgesia, so non-steroidals, opioids and local anaesthetics. If we're trying to treat pain in a perioperative setting, Carl has already said treat, reassess. Opioids, if we think we've got pain, we should be using opioids, and we shouldn't be afraid of using opioids. Non-steroidals, my approach with non-steroidals, dogs, cats, acute pain. If you have a dog or a cat and they are acutely painful, you should give a non-steroidal unless you can find a very good reason not to. That's where I'd start with non-steroidals. And one of the reasons we started Zero Pain was to encourage the use of local anaesthetic techniques. And it just made me remember we've got a free webinar on the site called Let's Add Local. So if anybody does want a little intro into what we do, please take a look at the Let's Add Local webinar. Yes, it's a kind of, I think it's a half an hour webinar that just introduces how you could do this today, tomorrow in your practice. So those would be my kind of tips for an acute point of view. From a chronic pain point of view, I think where most people really struggle is just taking a drug approach. We prescribe a drug, client comes back, didn't work. That's really not helpful. I think it's the worst consultation, isn't it? You've got a busy clinic. All right, okay, I'm seeing Buster back. Come in, client says, well, those drugs you prescribe haven't done anything. Oh no, what do I do? Where do I go? That's really hard. So wind back in order to prevent that happening, or to try and get a better handle on the pain. So what are the pain behaviours? So ask the client 3 to 5 behaviours that they associate with pain in their individual patient, their pet. That could be things that the dog used to do that they don't do anymore, or new behaviours that they have started doing. And it might be things like, okay, if there are 2 steps up to the front door and the dog trips going up, that could be a pain behaviour. And we can often pick these out of our history. So when the client comes in and they start telling us the history, I'm there writing down those behaviours as they mention them in the history. And I might then specifically ask them, okay, are there things that he used to do that he doesn't do anymore? And an example might be, my dog takes a long time to get into a comfortable sleeping position. That's a pain behaviour. Is that going to improve with our analgesic prescription? So we write those things down and we say we're going to talk about those in our next consultation. I think the other thing I would add is whatever you do from an intervention point of view, let's say you prescribe X drug, we need to give that drug long enough to actually work and to do something. And the question there is, okay, is it because it takes that drug that long to start working, or is it because it takes that long for those pain processes to start to unwind and for the patient to start to become comfortable? And we understand from a very simple example is the use of non-steroidals. We know that if you pain score a patient prescribed a non-steroidal with osteoarthritis for 8 weeks, those pain scores will decrease over that 8-week time period. So I tend to say to clients, I'm going to prescribe this drug to you, and we're going to make an outcome assessment in 3 to 4 weeks' time as our first step. So don't be too hasty in making your assessment as to whether that drug has been effective. And I've got to think of a third one, haven't I? I could give you a very long list. I think my main thing would be that we need to zoom out and consider the everything matters approach. So, okay, we have the ability to prescribe drugs, but lifestyle management, weight control, diet, exercise, all of those things are so key in managing chronic pain. Yes, so don't just zoom in on the drugs. And I think if you start that conversation with a client in the first consultation, they also need to be aware that we are not prescribing a magic bullet that's going to fix their pet. Everything else matters. So it doesn't matter if I prescribe a drug. If they don't do the hard work with the exercise control and the diet to reduce the weight, we're not going to get anywhere.
Do you regularly get your owners to video their pets at home? Because I would imagine another challenge is that they act differently in clinic than they do when they're at home. And I think the other thing I always think or wonder about is sleep. So if an owner says they struggle to find a comfortable position to sleep, some pets will sleep more when they're painful. Some pets will sleep more intermittently because they can't get comfortable or they move. So does it help to have video evidence?
Yeah, really interesting. I think it makes me laugh actually, because you sometimes get that client in a consultation that whips out their phone and says, "I'll show you a video," and they've got a million videos of the ceiling and the floor. And you think, oh, here we go. But actually, all jokes aside, so useful to have videos, because you get a dog that comes into a consult and it just curls up on the bed in the corner, and then you have to get that dog up, examine it. You're in a totally artificial situation. So what we're looking at is the behavioural, what we're trying to assess, is the behavioural impact of that pain. Me examining the dog, that does give me some really valuable information. That tells me, okay, on examination, how painful do I think the dog is, but it's not measuring the impact of the pain on that behaviour on a day-to-day basis. So the videos can be really, really useful. So I would say to clients, if your dog has some type of episodic pain, they do strange things like they back into a corner and they stand there, please get a video of that. Please get videos of when your dog is doing those abnormal behaviours. Or that dog that takes a long time to settle into its bed, let's get a video of that. So yes, videos can be incredibly useful.
Can you use them to distinguish between musculoskeletal pain and a neurological condition as well, if you're weighing that up?
I guess if it's a good video, you can often distinguish a lameness from a proprioceptive deficit, but it does need to be a good video.
I was going to say, and so you'd say the same about pain scoring. You wouldn't pain score on a basis of a video.
I think quite difficult to pain score on the basis of a video, and those are difficult consultations. So I've done a lot of remote consultations where behaviour, where if I can't physically examine the dog, is it worth putting a dog that's severely emotionally challenged in a car, bringing it to a vet clinic to sit in a consult room where I'm going to talk to the client and I can't examine the dog? You are always limited when you can't get hands on, and that is just one of the challenges we face. Sometimes there's no point in me muzzling a dog, stressing it to examine the dog and have it growl at me, because that is the worst thing for that dog in that individual. We're just making the behaviour worse. We have to accept that by looking at that video, there is only so much information you can gain. Because I always say, part of my examination, I want to get hands on. I want to do a touch exam to start. I need to know where the sensitivities are. I want to know what the impact of the muscles is from, if you have joint disease, for example. There's so much value in examination that sometimes we just miss because we have to work with those emotionally challenging patients. And sometimes you do end up working on your best case scenario. You make a prescription and then you say to the client, okay, let's look at those pain behaviours. Do you think your pet has improved? So yeah, sometimes we're not always working in the most ideal situation in those cases, but you have to do the best you can in the circumstances you're given.
Do you muscle score regularly?
I am probably not as specific as a physiotherapist in specifically muscle scoring. When I examine, I'm assessing for touch sensitivity to start with, then normal muscle size, normal feel to the muscle. And then I go in for a deeper trigger point examination to find out where the sore spots are in muscles. And if you take your typical Labrador with osteoarthritis, elbow osteoarthritis, they will have really rock firm triceps because their triceps are just in overload, and they've probably got quite small biceps muscles from trying to sustain that painful elbow joint. And then if the dog is in a relaxed position, those muscles still feel tense, and you'll often find really sore trigger points within those muscles, which is another pain driver. So you've got a painful elbow and you've got the pain driver coming from the muscle. Those are the cases where I think there's a huge value to physiotherapy. Physical therapy is a hugely useful component of managing those cases. And I work really closely with physiotherapists on managing those cases.
Amazing. And so we have some veterinary physiotherapists here in the UAE. Would you recommend sort of referral to them very quickly when you have a chronic pain case? And in fact, when you have surgical, so like perioperative pain and surgical recovery, do you work with physiotherapists there as well?
I will. I think talking about the acute pain setting, definitely. We're really lucky because we've got physios on site at the hospital, and recognise the value of getting them involved really early. So if that is something that's possible, referral to them from a primary care setting, then I would absolutely engage with them, particularly in patients that have already perhaps got osteoarthritis, they're presenting with the cruciate rupture, they're having a surgical procedure. Getting those patients as part of their recovery from the surgery, getting the physios involved from day one is a really important part of that kind of that first 6 weeks really post surgery. And there's a really interesting concept in people which is called early recovery after surgery, ERAS. Now, it's really big in human medicine in various different types of settings. It's new to vet medicine. There's not much in the literature yet, but there's a good understanding that if you can get some of those variables right, of which physical therapy is part of that, then you're likely to have a better recovery for that patient, for that pet as well. And physical therapy is a really important part of that. So our physios will be involved from the next day with those patients with an orthopedic case. So if they've had stifle surgery, for example, the physios will assess them the following morning. Our physios do the discharge as well. So they'll discharge the pet back to the client and they'll run through what the client could do at home with them, what's going to be possible. And if the client's on board with coming back, then the physios will see those dogs back for 6 occasions post their surgery. The other setting, the other really valuable part of the neuro patients, so patients that had spinal surgery, for example, so your kind of chronic slip disc extrusion surgery, then the physios will be heavily involved with those patients, particularly if they've got neurodeficits, which a lot of them will do in the recovery phase. The physios are really heavily involved in that part of the patient's kind of treatment. So while they're in the hospital with us, they'll be having daily or twice daily physiotherapy as well. So yeah, really valuable part. And the thing that really hits for the ERAS approach for me is around that multi-team approach. It's, as Matt mentioned, it's not just about giving lots of drugs. It's really easy to prescribe, but it's getting the other bits right. And that's the great thing about having physio, particularly when they're there with us. We're really lucky if that's the case, but otherwise definitely recommend referring.
What other variables form sort of part of the ERAS approach?
Yeah, that's a really good question. So we think of the analgesia is really important, and like Matt mentioned, multimodal analgesia, incorporation of a local anaesthetic technique, that's really one of the most important things they're recognised in people. If I look back, definitely over the last 5 to 10 years, we've gone from doing very few nerve blocks to, I think probably now, at least 90% of the patients that we operate on, we're doing some sort of nerve block with. And over the last 3-ish years, maybe 4, 5 years, that's moved to using ultrasound, so using ultrasound techniques to get those nerve blocks. So we're becoming more targeted, hopefully improving safety, and it's giving us a real amazing repertoire. The literature, every month there's a new block that's been described to use in a dog or in a cat, for example. So that's really changed.
Are those transferable to be used in general practice, ultrasound guided, or would you need further training?
Question. I think training definitely. Often once we're starting to think about adding ultrasound in, we're probably doing something that's perhaps a more advanced technique. But I think the great thing about a lot of vets are using ultrasound for other applications. So they're doing abdominal ultrasound, I suppose very commonly. They might be doing, POCUS scans, chest, abdomen as well. Finding a nerve and looking for a needle with ultrasound, that's the training part there. If you can use the probe, you're halfway there already. If you can identify structures, obviously with some training around the particular techniques, identifying the needle, looking for the structure you're interested in, and then the kind of aspiration injection part, that bit can be very successfully taught. So I would say you can definitely apply that into primary care really successfully.
And I would come back to a really simple example I always use with enhanced recovery after surgery. What we should be thinking about with that individual procedure is what is the outcome that I want to see improved. if you take a cat that's having extensive dental extractions, what do we want the outcome to be? We want that cat to be comfortable in recovery and to eat, ideally before it goes home, or definitely eat when it's at home and continue eating well. We recognise that if you incorporate local anaesthesia into those dental extractions, maxillary and mandibular nerve blocks, those cats are going to eat so much better. And that's the feedback we get when we go into practices and we teach them dental nerve blocks. The feedback you always get is, wow, we're amazed how well our patients eat before they go home. And everybody feels better. Patient that eats after surgery,
Yes.
oh, you've done your
Especially
job.
a feline patient. A feline patient that eats after surgery.
Yay.
Yeah. And then everyone's happy because they get to go home earlier.
Yeah.
The owners are happy.
Yeah. You definitely don't want those clients at home, 8 o'clock at night, 10 o'clock at night, phoning the out of hours vet with a problem. We want to make sure that there are no problems.
I suppose in human medicine, it was obviously generated from trying to get people out of hospital. Having a person in hospital for a long period of time, well, one, it's costly to the health service, but also tends to impact on recovery. And I guess we don't recognise that necessarily as a problem for vet medicine, because we tend to send a lot of patients home maybe the same day anyway. But getting those other key things right. So actually the other aspect that's really picked up on is around, as Matt mentioned, appetite. So use of anti-nausea meds as well is something that's definitely recognised as part of ERAS. And that ties in what we talked about earlier, which is around use of opioids. So the impact of opioids on appetite because of sedation, because of nausea is a really big part. So using the local anaesthetic technique to reduce the requirements of the other systemic drugs is a really key part of incorporating them, getting them eating, getting them home. So that's a great part.
And you do cover the ERAS, don't you, in one of your podcast episodes? So that's
we've got
a good place
a
to start.
podcast on ERAS. And then one of the subscriber benefits we have is Zero Pain Reflect, which is a different style of CPD. So we digest 2 articles and then we ask reflective questions on those. So it encourages a more modern style of learning. And we have one of the Zero Pain Reflect articles is on ERAS. Yeah, so plenty of information out there for people.
Brilliant. Now, this is also, my next question is more of a sort of personal question. Do you use, and tell me about them, laser when you're looking at pain relief, and do you advocate for acupuncture? So those are always, when I've had a look at the research, it's very mixed, depending on what machine you're using, depending on who's telling you about the research or who's funded the research, let's just say. What is your opinion as an independent specialist?
And I'll go back to the question on physio. When I see a new case in the chronic pain clinic, in that first consultation, I'm thinking, should you see the physiotherapist? And one of my colleagues, 2 colleagues I know, they actually do their first consult with physio and pain specialist together in the same room. So that is a very valid approach, I would say. There is a huge value to physiotherapy. I think I said before, using drugs to treat muscle pain is not always the right way to go. I'm a firm believer in physical therapy, and it's part of physical rehabilitation is part of the everything matters approach. So yes, early involvement with physiotherapy. Laser is a really interesting one because back in 2017, I did a presentation to BSAVA Congress and I looked through the literature, and the literature at that stage was not terribly convincing. And I wasn't working with a physiotherapist at that stage, and we didn't have a laser. And for me to go to my boss and say, right, okay, here you go, boss, here's the evidence. Can we have a laser? And the cheapest one was a type 3B laser, which is about £4,000 or £5,000. Didn't have the evidence at the time. And other lasers were a lot more expensive than that. And there wasn't really the evidence to support that. Having worked with physiotherapists since, physiotherapists would say laser is absolutely essential to my practice. And then having seen those cases and worked with a lot of cases where muscle injury and muscle pain is the primary problem, laser is really, really useful in managing those cases. So I'm convinced that laser has a huge value to offer. I will often use laser in cases where I think I would really love to acupuncture that patient because they've got trigger points in their muscles that are really sore spots, but they're not going to tolerate it for whatever reason. Maybe the dog's anxious, stressed, acupuncture is not an option. Going down the laser route with the physio, laser and massage is a much better route for managing those cases. okay, if I can get needles in those patients, then absolutely, yes, I will. And I would say acupuncture is hugely beneficial if you take your typical older arthritic dog, that dog will respond very well to acupuncture. In my experience, there are lots of skeptics and the evidence is challenging. However, I see a huge role for acupuncture in managing pain, certainly in osteoarthritis and definitely muscle pain. And maybe we're talking about two slightly different mechanisms there. So if we're using acupuncture, we're using acupuncture points, a lot of those points actually coincide with where we would typically see trigger points and painful areas in muscles. That's what a human physiotherapist would refer to as a dry needling technique. So I'm never quite sure whether I'm performing traditional acupuncture or dry needling, but my approach is to find out where the muscle is painful and target those painful areas.
And I think I've always made the quiet assumption that if we're seeing a benefit with acupuncture in a dog or a cat, they don't have the preconceived notions that we might do as humans, and therefore the kind of inherent bias to either believe that it has worked or believe that it hasn't worked. So I've always taken that as a bit of validation for me to say, well, it works. They didn't know they had acupuncture and they don't know if they think it works or not. So
yeah, and I think there are two elements to that. It comes back to our outcome measures. And if we have a clear idea of what the pain behaviours are from the caregiver and they see a resolution of those behaviours, then that is much stronger. I don't hesitate to use the word evidence, but that's much stronger than the client saying, oh yeah, it definitely works, because the client has an inherent bias. There are clients that want it to work and there are clients that don't want acupuncture to work, and we definitely see that. And we can absolutely influence how a client thinks with the way we portray a treatment in the consultation room. So this magic new pill that's really cheap is absolutely going to work in your dog. Well, yes, doctor, that might work much better than that really irritating, expensive one that hurts my dog, blah, blah, blah. I can't get down my dog.
We have a lot of challenges, don't we, really, when you're dealing with a pet owner and a patient and then everything else.
Sometimes I think it's easier because our pets can't speak. I'm not quite sure it always works out that way.
Definite pros and cons. Definite pros and cons. Do either of you have any last-minute comments or last-minute thoughts that you really think our veterinary community need to hear before we wrap it up?
It's the recognition. Recognise that there is pain and then treat it. That's got to be my
That's
key
the key. That's where to
take-home.
start.
Yeah, absolutely.
Okay.
And I would say if you think there is pain, yes, we should treat it. In a chronic context, we introduce the topic of pain trials. So if anyone wants a little bit of homework, there is a pain update on pain trials on our website. So that would be a really good place to start.
Thank you both so much. I hope you enjoy the rest of your time here in the UAE.
Thank you so much.
you.
It's great. Thanks for the invitation.